I'm Stephanie Bernard. I'm a musculoskeletal radiologist at Brooke Army Medical Center in San Antonio, Texas. I'm going to be covering a radiographic approach to arthritis. This is part one of a three-part series on the radiology and pathology of arthritis. By the time you're watching these, hopefully my radiology lecture slides will be seamlessly married with the pathology component of the lecture. The live video conference time will be used for you to demonstrate your prowess with interpreting arthropathy radiographs based on the principles in these three lectures. The objectives of part one are to review the radiographic features to look for and the arthropathies that contain them, focusing primarily on the most common erosive arthropathies listed here. The key features that are typically discussed are the presence of erosions, bone productive changes, and disease distribution in identifying arthropathies. But we're going to discuss a few more features that I think can help fine-tune a diagnosis. I start my evaluation of radiographs with looking at the soft tissues, as they can draw your attention to sites of settle abnormalities and can help make the diagnosis. One pattern of soft tissue abnormality is fusiform soft tissue swelling, as in this case at the third proximal interphalangeal joint. This pattern is typically seen with inflammation, and that can be from injury, infection, or inflammatory arthropathy, as in this case, rheumatoid arthritis. And it's a common early finding in early rheumatoid arthritis. Another characteristic soft tissue pattern is what is referred to as a sausage digit. It is a dactylitis swelling pattern. This pattern is classically associated with peripheral spondyloarthritis, as in this patient with psoriatic arthritis. Another distinctive pattern with classic differential diagnosis is the lumpy-bumpy pattern, with asymmetric mass-like areas of soft tissue thickening. While you can see that there are several diseases that can produce this type of pattern, gout is by far the most common entity that you'll see with this pattern. Occasionally, it's the loss of soft tissue that may be the only finding of the disease. Normally, there is more than half the diameter of the distal phalangeal shaft worth of soft tissue over the tip of the fingers on the PA view. When comparing to the normal on the left, the patient on the right has a loss of soft tissues distally. Now, this can occur with collagen vascular diseases like scleroderma, as in this case, but may also be seen with vascular insults or peripheral neuropathies. As the soft tissue loss progresses, there may be an underlying acroosteolysis. Also pay attention to the soft tissues for calcifications, because they may be crucial to figuring out the type of arthropathy you're dealing with. You all have probably seen the spectrum of soft tissue calcifications many times. If you critically look at them, you'll be able to tell most of the time the type of calcification. This is CPPD, often appearing stippled or in linear brush strokes of calcification in cartilage structures and in tendons. Here it's in the TFC disc, as marked with the arrow, but it's also seen in the intercarpal ligaments in the proximal carpal row. Contrast that with hydroxyapatite deposition, which is globular and amorphous calcification in the tendons, most commonly seen in the rotator cuff tendon, as in this patient, but may be seen in any tendon anywhere in the body. Another frequently encountered is gout. Uric acid crystals by themselves are radiolucent, so you may only see a mass-like lumpy-bumpy soft tissue thickening plus minus inflammatory changes. But frequently, calcium will precipitate with the monosodium urate crystals, so they often have density. When starting to evaluate the joint, pay attention to the pattern of joint space narrowing. Uniform joint space narrowing, where the subchondral bone plates look to be settling together, is a feature of an inflammatory process within the joint, resulting in diffuse cartilage loss, as in this case, a monoarticular area of joint space loss from infection, the result of a fight bite. But here, same uniform joint space loss with rheumatoid arthritis. Those are a very different disease appearance when compared to the asymmetric cartilage wear typical of osteoarthritis, where one side of the joint is narrower than the other side of the joint, resulting in angulations and subluxations, something I'm sure you all are very used to seeing in multiple joints. Here, asymmetric medial joint space narrowing in the knee and supralateral joint space loss in the hip, characteristic of osteoarthritis. We then need to search for erosions, and they can be quite subtle. Zoom in. There are different types of erosions, and the locations also mean something, so pay attention. You may hear a radiologist describe an erosion as aggressive or active. The idea is that these are erosions that are actually changing while you're looking at them. They lack a sclerotic border. These will begin in the bare area of bones at the margins of joints where there's no cartilage protecting the bone and where it allows direct synovial contact. The erosions begin by whittling away at the white cortical line and margins of the joint. Compare this normal contour and normal continuous white cortical line of this normal third metacarpal head with this dot dash erosive configuration and the loss of the normal contour of this swollen second metacarpal head in a patient with early rheumatoid arthritis. As the disease progresses and the inflammatory cascade and collagenases remove the remainder of the cartilage, the erosions will progress to the central portion of the joint. Again, we're expecting symmetric joint space loss because it's inflammatory in this patient with rheumatoid arthritis. Now contrast that, those prior aggressive erosions, with these sclerotically marginated erosions. They're so indolent that the osteoblasts, as slow as they work, have had time to repair the margins and lay down a white corticated line. These sclerotically marginated periarticular erosions, shown here, with lumpy, bumpy soft tissue deposits at the great toe MTP joint, are a classic gout. The location of the erosion is also helpful. Here are aggressive erosions at the margins of the distal interphalangeal joints of the fourth finger. You may also have noticed that there's a bit of a sausage digit and some extra bone formation on the edges of the distal phalanx next to the erosion when compared to the adjacent more normal joint. All of these are classic features of psoriatic arthritis, a spondyloarthritis. Compare that with the central erosions creating the characteristic seagull wing configuration of the second proximal and fourth better than fifth distal interphalangeal joints, typical of an erosive osteoarthritis with well-defined marginal osteophytes. And similar to the case from a few minutes ago, the erosions here aren't in the joint, but adjacent to it, periarticular. Here sclerotically marginated, and with the joint space preserved, and with a dense, lumpy, bumpy mass adjacent to the joint, another classic example of gout. In many of these cases, we've seen examples of bone production as we've gone along. Let's talk about that specifically. There are two primary types of bone productive changes. Proliferative new bone formation, the fluffy periosteal bone formation that happens at entheses, tendon and ligament attachments, capsular attachments, and adjacent to erosions. Here seen in the second and third in comparison to a more normal bone contour in the fourth distal phalanx, as well as ankylosis of a joint where bone has bridged the joint space. These are all proliferative new bone formation that's characteristic of a spondyloarthropathy. Psoriatic arthritis, typically in the hands, potentially psoriatic or reactive arthritis in the foot. In comparison, reparative bone formation is what you're typically seeing in osteoarthritis, where it forms osteophytes. It has subchondral additional bone formation that looks like sclerosis on the plain films. Here in a knee with classic osteoarthritis. The last of the features that will help us put the whole case together is the distribution of the disease and how many joints and which joints are involved. When we come across a monoarticular inflammatory process, the diagnosis of the exclusion has to be infection. If it turns out to be a crystalline arthropathy or some type of mass-like synovial process, great. When we are dealing with only a few joints involved, the most common ones to give you that are either gout or spondyloarthritis. Whereas rheumatoid arthritis is classically described as bilateral, symmetric, but the other disease that you have to think about with that is psoriatic arthritis, which has a variant that looks almost identical to rheumatoid. So when I deal with a polyarticular disease, then the next thing I ask is what joints are involved. In the hands and feet, You'll notice I outlined DIP. One diagnosis not in that differential is rheumatoid arthritis. Rheumatoid arthritis is exceptionally rare in the distal interphalangeal joints, whereas psoriatic arthritis really loves the distal interphalangeal joint. So if I'm dealing with a polyarticular arthropathy and the DIP is involved, I'm going to favor that one being psoriatic arthritis or something else, but not rheumatoid arthritis. So that concludes part 1. I'm going to leave you with these 4 radiographs, 4 patients with different types of erosive disease. See if you can figure out the diagnosis for each. I will tell you that when we get together for the arthropathy case session, I'm going to be starting off the case quiz with these 4 cases. So thank you for your attention, and we'll continue on in part 2.